Thank you, Dr. Lang. I'm sure we're going to get questions about that. It's a very important issue that's being proposed through a number of individuals about, again, aggressively treating that local cancer in the setting of spread. So it's a pleasure to introduce Dr. Bruce Montgomery, who's my twin, maybe. Different mothers, but we look alike. So Bruce Montgomery is a professor of medical oncology at the University of Washington. He's really a world expert in the treatment of advanced prostate cancer, and in particular, some of the new subtypes of prostate cancer that have been identified that through targeted biopsies we can understand how best to develop new therapeutics targeting them. So he's going to give you some, really a glimpse into this really exciting area. Bruce?
Okay. Thanks. Can you folks hear me? Get this a little bit closer. How's that? Can you hear me? Great. Okay, so you heard Dr. Lang talk a little bit about telling a series of stories, and that's really what I'm going to do today, because what I'm going to talk about is what's called precision medicine, but it's really what we talk about as personalized medicine. We're not going to talk about big randomized controlled trials. We're going to talk about how we can hypothetically go in and decide what's important in an individual's tumor and what we can do differently about treating that. So in the course of this talk, I'm going to talk a little bit about some of my patients because they participated in a study which I think has changed the face of prostate cancer in any number of ways, and sort of give you an idea of how that information that we gain from an individual cancer can be used in some very specific settings now, but with the idea that we are changing the landscape and the series of things that can be done about prostate cancer in a way that is now unprecedented. So when we talk about sequencing, it's kind of important to understand what that is. So in every single cell, there's DNA, and every DNA genome has 3 billion letters, let's call them nucleotides, okay? So the idea is that when your body turns over a single cell, you have to replicate those 3 billion nucleotides in a way that is exactly the same, okay? So when you do that, it's obviously critical that you avoid making a mistake, because a mistake ends up causing cancer, right? Which I think is obviously what we don't want. So your body has evolved this system of DNA repair so that it senses changes in DNA and then goes in and repairs them about as accurately as it possibly can. And so we have this process called DNA repair, which involves many, many different genes and proteins. Now, when that system goes awry, we get cancer, and when we get these changes in the DNA, those are oftentimes drivers, and finding out what those drivers are is what sequencing is all about. So when we talk about, you hear on TV about many different ways of doing sequencing. So you'll hear about things like whole genome sequencing, which means literally sequencing every base pair in that genome. Okay, that's a lot of DNA, and a lot of that DNA is irrelevant. There's what's called exome. That's the part of the DNA that is turned into protein. So that's, a lot of people are focusing on whole exome sequencing. Most of the commercial assays that you know will hear about are really looking at parts of the genome that we know have some importance in terms of the treatment of the cancer or driving the cancer, so that it's prognostic. And so it gives us information that's important in terms of treatment. So the thing that it really isn't talked about when you hear these sound bites on TV is that not every mutation has any relevance, okay? When a cancer cell is just turning over and it's not able to repair DNA accurately, you get all sorts of mutations that have nothing to do with anything important, okay? Those are called passenger mutations. Driver mutations do something different about the biology of the cancer, or they can predict for a specific therapy being effective or ineffective. And those sorts of things are obviously critical when we're talking about treating somebody. So when we also hear this term actionable mutations. So what that really means is a mutation that you can use, okay? So there are two classes of those. One that is a mutation that we can use today, meaning that there's an FDA-approved therapy either for the disease we're talking about or even another cancer that we can hypothetically get approval to use in, let's say, prostate cancer. or there's a mutation that might allow somebody to participate in a study looking at research agents, things that are trying to improve outcomes for men, and that's an important association. That is, it's something that might tell you that a drug that's being tested could be more effective. So this is the sort of the money shot of a study that I talked about last year. I'm going to reemphasize it because this study has changed the face of prostate cancer research. This paper gets cited at every single meeting I ever go to about prostate cancer. And we participated. In fact, we put more patients into this study than anybody else. And what it was it's called the Stand Up to Cancer PCF AACR Dream Team effort in prostate cancer. What was done was men who had advanced prostate cancer, meaning metastatic, who had hormone therapy and their hormone therapy wasn't working as well as we wanted anymore. Those folks very generously agreed to participate in a study in which we did a biopsy. And you heard a little bit about biopsies in several earlier talks. As Dr. Nelson mentioned earlier, biopsies, in fact, are not as odious as it sounds like they might be. We have biopsied many, many men, and the number of folks who have had problems is very, very small. So these folks went through this biopsy procedure, and then sequencing was done on the metastasis. And so this is a schematic of all the changes. Now, nobody can look at this and make any sense of it. You have to really, obviously, dig down and say, what are the changes in here that are relevant? So looks like that slide got changed. So the thing that actually came out of this that I'm going to focus on is what's called DNA repair deficiency. So out of these 150 men, and there actually are now 500 men who've been biopsied, but out of the first 150, about 20% of them had these changes in what's called DNA repair pathways, okay? Now, there were two classes of these. There's what's called homologous recombination, which is things like BRCA1 and 2, which we know are important in breast and ovarian cancer, and something called ATM. And then there are what are called mismatch repair genes that are important in things like colon cancer, because that's how people inherit a risk for getting colon cancer, is there are changes in these mismatch repair genes. These are also just a different type of DNA repair mechanism. So I've sort of told you my bottom line out of that slide, but the thing is that what we're looking at is DNA repair deficient tumors. There are potential therapies that I'm going to talk about in just a moment, something called PARP inhibitors. It's not FDA approved yet, but there's a large randomized study that's ongoing, and we can, in fact, get these drugs sometimes if the justification is strong enough. And there are drugs available today, chemotherapy agents that are less toxic than what we oftentimes use and more effective that we could use today. Then the other thing is what are called hypermutated tumors. These are these mismatch repair gene abnormalities, and Dr. Nelson is actually the one who has done most of the work in this, and I'll cite one of his papers in a moment, but the idea is that tumors that have this mismatch repair and are what are called hypermutated, I think actually Dr. Schweitzer mentioned this earlier, have the potential to be targeted by immunotherapy, and I'll show you why we think that's the case in a moment. So this is a story. So this is one of my patients who participated in the Stand Up to Cancer study. So he's a gentleman who had very, very high risk prostate cancer diagnosed back in 2009, was treated with radiation and hormonal therapy. Hormone therapy by itself after the radiation therapy was very effective up until about 2013, and things started to change. So this is a PSA graph of what his PSA did. Now his PSA was relatively low, but these changes in PSA, maybe I can, yeah. So changes in PSA here were reflective of things changing in terms of scans. So somewhere around 2013, PSA started to rise, and we started to use abiraterone, which was not very effective. He then got chemotherapy, docetaxel chemotherapy, which worked pretty well. He then got enzalutamide, which actually did also work for a while, but not for very long. And then he actually participated at this point in the Stand Up to Cancer effort. He had a biopsy done, and we started giving him everything that was FDA approved, cabazitaxel. I gave him docetaxel and carboplatin for a reason I'll talk about in a second. And he came in at this point, and he was miserable. He was in a lot of pain. We'd given him everything that was FDA approved for his situation, and frankly, it was all about, is anything else useful? Or should I just really focus on enjoying the time that I have? That, because we pushed very hard to get the stand-up to cancer biopsy results, they came in the day that I had this conversation with him, and he had what's called an ATM mutation in his tumor. So both copies of this gene called ATM were no longer present in his cancer, and that was pretty clearly a driver of his cancer. And as a result of that, we gave him a drug that's an old-time chemotherapy agent that we almost never use to treat prostate cancer anymore, mitoxantrone, because it's a DNA-damaging agent, and this ATM gene is a DNA repair deficiency gene. So the idea was, with mitoxantrone, he went from being so miserable that he could barely get off the exam table to being back, riding his horses, shoeing his horses, doing all that, and that's been the case for the last year. And in the last year, this paper that I'm going to show you in a second came out about a drug called olaparib, which is a PARP inhibitor. And he just started on the PARP inhibitor a few days, actually a couple of weeks ago, and his PSA has gone from somewhere, again, for him a PSA of 12 means something, and his PSA is down by over half within the first 2 weeks, okay? So that's one example, but that's, this is obviously very important to this gentleman, and participating in this study had a really big impact on his therapy. So I mentioned this, so this is what has happened in the last year since our last IPCR symposium. So this is a paper, this actually, the work that came out of this paper actually was part of that Stand Up to Cancer effort that I showed you the data on. And what was done was, it's been known for a long time that if cancers, mostly breast and ovarian cancer, have DNA repair defects, those cancers become reliant on a pathway that is absolutely dependent on something called PARP. So there were these drugs that were known about, PARP inhibitors, that actually got FDA approved in ovarian cancer within the last year and a half. And so somebody that we all know here, Johann de Bono, did a study where he gave 50 men with just metastatic resistant prostate cancer, PARP inhibitor, and he sequenced their cancers at the same time, looking to see if something in those tumors would predict for response. And in fact, he showed that about 16 of those men did have these DNA repair defects that had been defined in the Stand Up to Cancer set. And in those men, these are the men that had the DNA repair defects, and these are men who did not. And this is how long they basically responded to this PARP inhibitor. So the difference, we talk about hazard ratios for outcomes, and the hazard ratio for this was about 0.2, which is an 80% improved outcome for those men who had this DNA repair deficiency. So this is a huge change in thinking about the biology of prostate cancer, in that a subset, probably 25% of prostate cancers, will have a sensitivity to this drug, which we never thought would be relevant. And in fact, now there are, within the